One, we are live.
Hello, everybody. A very good evening to all of you. Welcome to the webcast of Hyderabad Nephrology Forum. So today we have an interesting lineup of cases which are going to come in the next 1 to 2 hours. So I'll be starting the program. First, there'll be a welcome address by Dr. Swanlata, followed by a website demonstration. So before I give it to the moderators, I welcome Dr. Swanlata to start off the proceedings.
Yeah, good evening everyone. Welcome you to the another episode of the Hyderabad Nephrology Forum activity. So we are happy to have this program. So we have trying to expand our program to include the nephrologists from across the state, from all categories of, right from the juniors to seniors. So we have tried to program in such a way that everybody is included in this program. So today we'll be having 3 sessions, one from the Dr. Shravan Nizamabad, and run from Dr. Dhananjay, he's from Continental Hospital, and from the Gandhi Hospital. So we want to also update about what is happening in Hyderabad Nephrology Forum. We have tried to upgrade our few of the activities, including the website. So website is going to be a more vibrant now with the updation of all the activities, including the Hyderabad local nephrology activities, as well as whatever is happening across the country and the worldwide. So we are also planning to have a newsletter quarterly, and we'll come up with a new activities, academic activities. And next month we'll have one program for the mock examination for the exam going students. So with this brief introduction, so I would now request Dr. Vikram, who is the in charge of the website, to have a brief presentation so that you can have a glimpse and you can try to regularly check our website for the activities. Dr. Vikram, please.
Good evening, everyone. I'll give a short introduction demo of our website, which is yet to be in the public domain, which probably might be from Monday to be in public domain. So this is what exactly the homepage looks like, and in about us, we have a brief introduction of Hyderabad Nephrology Forum, since how many years it has been active and what are the activities which are being done, and memorandum, aims and objectives. And after that, in the same drop down, we have patrons, the senior nephrologists, and the advisory board of the Nephrology Forum, which includes the senior nephrologists who have played an active role in running the Nephrology Forum. And next, we have council members. So the council members have been elected for this year. President Manisha Sahay Madam, Vice President Manisha Etla Madam, General Secretary Swanlata Madam, P.S. Vali Sir, Joint Secretary and Treasurer Dr. Raja Karthik Kalivindi, and Executive Members are Kiranmay Madam, Srikanth Gundapalli Sir, Dr. Praveen Ekta, and myself. And next comes the committees. There are academic committee, different committees like Scientific Committee, Social Media, Newsletter, Examination Committee, and Academic Activity Committee. And after that, we have bylaws and membership. Membership includes the information regarding different types of memberships and registration form, and also the directories. And the events which will be posted here are the past and upcoming events. And in scientific resources, as already Madam told, newsletters which will be released every quarterly. And e-library will be having e-books and journals, and we'll be having the forum event links. The past links and the today's link also will be uploaded in this particular site. In the calculators, we have regular EGFR and CKD risk protection calculators, which will be useful to the residents. And awards and accolades according to the year and month which uploaded. And recent in the month of April 2021, we have latest awards received by Dr. Chandni Kutta and Dr. Mukesh, who stood the first and second runner-up respectively in the national level Torrent Young Scholar Award for this year. And the next tab would be patient information, which includes dialysis hub, which has 3 hubs: Gandhi, Usmani, and NIMS, and respectively the spokes attached to these hub centers. And the patient education, we have Telugu book regarding kidney information, which is posted here. And regarding transplant centers, where exactly the transplant centers are, including the coordinators, and the statistics of the dialysis and transplantations will be updated here. And if any testimonials from the patient side will be uploaded here. And the gallery includes all the pictures from starting from the early days of nephrology in Hyderabad will be posted here. As of now, collected from only Osmania, and we're collecting them from Gandhi and NIMS. We'll post it here. And for any queries, you can contact us on the mail ID, and we have phone number here. And on the left-hand side, we have social media links: Facebook, Twitter, and Instagram. And on the right lower corner, we have chatbot. If any queries are there, which they can be posted here, and we try to reply as early as possible. For some reasons, I could not see this chatbot here, but it will be somewhere. It will be in the right lower corner. So this is a short demo of the website, which is going to be aired from Monday. So over to the moderator, ma'am.
Yeah, thank you, Vikram. So this is just an initial part of the development. So we'll try to, upgrade it further depending upon your feedbacks. And then I just request all of you to please share your activities or whatever information you have so that we can display. It is also, patient friendly, because patient also can access and find their own, dialysis center nearest to this place, or whatever scientific information they want, or patient information also is available here. So we'll try to develop over a period of time. So I think this is the initial part of the development, and you can, regularly, visit our website for regular updates. Thank you, Vikram. And logo also we are trying to modify a little bit to be a little change in the colors, and then, the designing part as well.
So just one input.
Yeah.
Please include Dr. Rajmalai sir, Dr. Shastri sir, Dr. Neela madam as well.
Okay.
And other inputs I'll give you in person.
Yeah. Sure.
Okay,
yeah, to inputs are welcome to incorporate all those things. Okay. So over to Dr. Shrikant, please.
Thank you, Dr. Vikram and Dr. Swanlatha. That looks very interesting. I'm sure you'll take the website to newer heights. So without wasting much time, we'll move on to the scientific session for today. So the first, before the presentation starts, I'll give it to the moderators, Dr. Kiranma Ismail and Dr. Praveen Kumarita. We request you to please take over the proceedings for the scientific session. Thank you.
So good evening, everyone. Welcome you all to the Nephrology Forum of April month. So we'll, without wasting time, we'll start the cases. First case is an interesting case presented by Dr. Dhananjay sir. It's regarding non-HLA antibodies, negligence, not always a bliss. As we all know that immunosuppression is required even in case of HLA identical sibling transplants, because there is a role for even non-HLA antibodies in causing immunological rejection. So today we'll hear this special case from Dr. Dhananjay. Over to you, Dr. Dhananjay.
Chairpersons, please.
Thank you, Praveen. Thank you very much for the introduction. Shall I start sharing the screen?
Yeah, I request the chairperson, Dr. Vikram, to have one comment, and then you can start your presentation. Meanwhile, you can share your slide, please. Dhananjay.
Yeah. Good evening, everyone. So it's very important to see the HLA antibodies in our transplant setting, but even these non-HLA antibodies are also play a major role when there is a rejection, when there is a graft dysfunction. So we would love to hear from Dr. Dhananjay over next half an hour or so. So what does it say? So over to you, Dhananjay.
Thank you, sir. Thank you very much for the kind introduction. So I thank the organizers as well as all my senior colleagues for giving me this opportunity. Today I'll be speaking regarding non-HLA antibodies, negligence, not always a bliss. This is the slide showing overview of my presentation. I'll be starting with a case presentation, followed by introduction, targets for non-HLA antibodies, mechanism of production pathogenicity, clinical relevance, what are the evidences currently for these non-HLA antibodies, who should be tested for these antibodies, and how to detect and how to treat these non-HLA antibodies. Moving to the case, Mr. M, 34-year-old male, self-employed, diagnosed as CKD in 2019. He had bilateral small kidneys, native kidney disease not known, was not on regular treatment, developed SOB on July 21, and he came to our hospital. He was immediately started on dialysis. He had uremic cardiomyopathy also with moderate LV dysfunction. He was on dialysis for 6 months, had a native urine output of around 200 ml, no history of blood transfusions, no other sensitizing events. He was worked up for transplant. Mother was donor. Blood group was O positive. HLA match was 3/6. The CDC flow cross match as well as the DSA Luminex for class 1, class 2 by lysate assay was all negative. The patient was taken for transplant. He received standard dose of ATG of 1.5 mg per kg, single dose. He was also given salomedrol, 3 doses, 500 mg, followed by he was put on Visalone, tacrolimus, and MMF. We observed that his creatinine started to increase from third to fourth day and reached a peak of 3.8 mg per deciliter. At this point, we had done graft biopsy. We can see the graft biopsy report. Graft biopsy showed segmental glomerulitis, acute tubular injury, peritubular capillaritis, and focal C4D positivity, all indicative of acute antibody-mediated rejection. So this is the figure showing the antibody-mediated rejection. Here we have varying levels of acute tubular necrosis. And in this slide, it is seen that there is focal glomerulonephritis, and here it is showing focal C4D positivity. So we did this post-transplant DSA again by Luminex method. Surprisingly, both the class 1 was negative and class 2 was also negative. So we went ahead and we did single antigen bead analysis, thinking that since DSA by Luminex is a crude method, it might have missed the HLA antibody. But both the class 1 and class 2, the single antigen bead also showed there was no DSA. We started treatment for him. We gave 3 doses of methylprednisolone. He received 4 sessions of plasmapheresis of 2 volume exchanges. And at the end of each session, we treated them with IVIG 10 grams. Graft function slowly improved to 2.1 milligram per deciliter and stabilized at the same level. Even recently, 1 week back when he was seen, his creatinine was 2.13. Out of curiosity, we had sent his MICA antibodies because I knew this was being done in IKDRC. Surprisingly, the MICA came positive. So with this introduction, I'll move on to the HLA, non-HLA antibodies and their treatment. So we all know kidney transplantation is the preferred modality of treatment for end-stage renal disease. We also know that occurrence of pre-transplant donor-specific anti-HLA antibodies poses a major risk, and it results in acute antibody-mediated rejection, which results in kidney graft loss. But we have seen multiple publications which says that antibody-mediated rejection or C4D deposition can occur in absence of circulating DSA. Also, in a very important article by Terasaki et al., it was reported that graft loss can occur in HLA identical kidney transplants also. These two highlight the importance of non-HLA antibodies in causing rejection. So non-HLA antigens are the antigens which are expressed on endothelial cells, epithelial cells, parenchymal cells, and circulating immune cells. These non-HLA antibodies can be directed against autoantigens or alloantigens. They may also be present. These antibodies may be present pre-transplant, or they can be formed de novo post-transplantation. So these are the targets for non-HLA antibodies. The list is long and it is growing with each year. For the kidney transplantation, the molecules of importance have been highlighted here. They are MHC class 1 chain related A gene, AT1R receptor antibodies, antibodies against collagen type 4, anti-perlecan antibodies, anti-vimentin, and anti-ICAM or anti-endothelial cell antibodies. I will be detailing about these antigens and antibodies in the subsequent slides. So this cartoon shows the distribution of non-HLA antibody targets. Most of the non-HLA antibody targets are expressed on the endothelial surface. You can see here FLT3 ligand, G protein coupled receptors, that is AT1 receptor, endoglin, endothelial receptors, ICAM4 are all expressed on the endothelial surface. On the extracellular surface, we have perlecan antigen with its LG3 subdomain. Coming to the mechanism of HLA antibody production, ischemia reperfusion injury or alloimmune, which is occurring at the time of kidney transplantation, exposes the cryptic antigens that are till here will be hidden from the immune system. This antigen exposure results in production of antibodies as well as autoantibody recruitment. This subsequently leads to complement activation, leukocyte infiltration, and increased severity of vascular rejection. So the ischemia reperfusion injury leads to microvascular damage. This microvascular damage causes peritubular capillary loss, and the peritubular capillary loss leads to interstitial fibrosis and tubular atrophy. The vascular injury which is occurring at the time of transplantation also causes endothelial apoptosis. This endothelial apoptosis releases apoptotic exozyme-like vesicles. These exozyme-like vesicles contains proteasomes which exacerbate or augment autoantibody production, which further damage the graft. So coming to the relation between HLA antibodies and non-HLA antibodies, the inflammation that is caused by non-HLA antibodies sequentially upregulate the HLA expression. They increase the risk of the patient to develop specific antibodies. Then the allograft becomes more susceptible to alloimmune response, and both the cell-mediated rejections as well as antibody-mediated rejections increase. This lowers the graft survival rates compared to patients with either HLA or non-HLA antibodies. It is also assumed that HLA and non-HLA antibodies have synergistic effects. Coming to the pathogenicity of these non-HLA antibodies, non-HLA antibodies may cause graft damage by fixing the complement, or they may be non-complement fixing antibodies. Typically, the anti-vimentin and MICA antibodies are complement fixing, whereas AT1 receptor antibodies and anti-endothelial cell antibodies are non-complement fixing. They also cause injury by antibody-dependent cell-mediated cytotoxicity, which results in cell lysis and cell death. These antibodies also cause structural changes in the arterial wall, which results in peritubular capillary loss and subsequent graft damage. Some authors have suggested that non-HLA antibodies may just represent a marker of injury or humoral activation, and they may not have pathogenic potential. But even then, these non-HLA antibodies may be used as biomarkers of ongoing immune response, and they may herald the need for more suitable immunosuppression. It has been shown that the non-HLA antibodies have much stronger role in clinical transplantation than that has been previously thought. 10% of the cases with C4D positivity fail to show circulating antibodies as our case, and it is suggestive that non-HLA antibodies need to be considered. Non-HLA immunity is also associated with chronic graft loss, unlike the HLA antibodies, which causes acute or hyperacute rejection, which leads to graft loss. Moreover, the influence of these non-HLA directed immunity was similar in magnitude to that of antibodies when these patients are followed on long term. That means it results in chronic graft loss as significantly as these HLA antibodies. Coming to the evidences regarding these different antigens and antibodies. First, I will be speaking about the anti-MICA antibodies. The MICA is found in the chromosome 6 short arm. It is similar in structure to MHC class 1, but the only difference is it will not bind to beta-2 microglobulin. Also, it doesn't present antigens to T cells. It is the first reported non-HLA antigen that is found to be important in renal transplant outcomes. It is the most extensively studied non-HLA antibody, and it is not involved in antigen presentation to T cells. The exact mechanism by how these anti-MICA antibodies are produced is not known. it is believed that the sensitizing events like previous pregnancy, previous transplant, and blood transfusion, just like in HLA antibodies, will lead on to formation of anti-MICA antibodies. So this is a seminal article which was published in NEGM, which looked at the antibodies against MICA antigens and kidney transplant rejection. This was done by Zhou et al. It is an international collaborative study that was done in 20 centers across 13 countries. This experiment was just performed blindly by testing MICA antibodies. They did not have any knowledge regarding the outcome of these antibodies. They looked at around 1,910 kidney transplant patients, including both deceased as well as live transplants. In them, 217 patients were found to be MICA positive and 1,693 patients were MICA negative. When the graft survival at 12 months was compared between these two groups, the patients with MICA positive had inferior graft survival when compared to MICA negative. When they just looked at only live donors, then also the graft survival in the MICA positive patients was inferior to MICA negative patients. The first identification of MICA as a polymorphic antigen was published in this paper. This was followed by detection of MICA antibodies in patients who are awaiting kidney transplantation as well as in the post-transplant course, and they showed that increased level of MICA antibodies were found in patients who were rejecting. So there were articles from Indian studies also which looked at post-transplant development of MICA, and they showed that these antibodies are associated with acute rejection. So the Cox and others co-workers screened a 442 renal transplant recipients for MICA antibodies. They used 3 different Luminex-based single antigen kits, one by 1 lambda, another by GenProbe, and they developed an in-house assay. The MICA was considered positive when 2 of these 3 tests showed similar results or positive results. MICA mismatching was found to be an independent significant risk factor in this study, and MICA and HLA antibodies were significantly associated with acute rejection. MICA DSA and HLA DSA also correlated with decreased graft function. So following these 2 studies, there were surge of case reports where they demonstrated acute rejection in patients who are possessing MICA positive antibodies. So as late as 2012, there is a very big article which looked at 779 kidney transplant patients who completed 1 year of transplant. They found that these patients had 5.4% prevalence of MICA antibodies. Surprisingly, the authors noted that there was no significant difference in 4-year death censored graft survival between MICA positive and MICA negative patients. This was in contrast to all the previous studies. And after this, there are many studies which showed that MICA did not cause any problem to the graft survival. So at this stage, MICA and regarding MICA antibodies, there are conflicting reports. One group is showing that there is increased risk of rejection. Other groups says they are just a marker of injury, they are elevated, but that does not lead to rejection. Coming to anti-AT1R antibodies, AT1R is a G protein coupled receptor that is expressed on endothelial surface. First, elevated levels of these AT1R antibodies were seen in severe steroid refractory vascular rejection and malignant hypertension that occurred in absence of HLA DSA. So this article published in NAGM studied 33 patients who had vascular rejection. In them, DSA was positive in 13 patients, and in all of them, AT1R is negative. DSA was negative in 20 patients, and among these DSA negative patients, AT1R was positive in 16 patients. At the end of the study, authors concluded that AT1R positive but DSA negative patient had severe vascular rejection and had much more rapid graft loss than even the patients who had DSA and HLA positive antibodies. The graft biopsy here did not show any complement deposition. Subsequent studies confirmed similar findings. This is another interesting study which looked at 97 patients. Here, HLA antibodies and MICA matching was done in all these patients who had developed rejection. So HLA and MICA DSA were negative in 63 patients. Among them, 16 developed acute rejection, 7 had acute antibody mediated rejection, and 9 had cellular rejection. Among these 7 patients, 6 patients had AT1R receptor positive. The authors opined that the AT1R antibodies are associated with increased antibody mediated rejection, but they are not associated with acute cellular rejection. This is another study published in Kidney International. The investigators hypothesized that circulating AT1R antibodies identifies patients at increased risk of rejection. They did a prospective study of 1,845 kidney transplant patients. DSA and AT1R antibodies were measured at rejection and 1 year after kidney transplant. 20% of them had AT1R antibodies, 20% had DSA, and 7% had both. Here we can see that patients with AT1R antibodies identifies kidney transplant patients at high risk of allograft rejection and graft loss. So this slide shows regarding studies regarding anti-endothelial antibody receptors and early renal transplant outcomes. Anti-ETR antibodies were studied in 116 renal transplant recipients. So among these 116 patients, 55 patients were positive for anti-ETR antibodies and 61 were negative. When they looked at the graft function in these 55 patients, the mean serum creatinine was 1.8 milligram per deciliter in anti-ETR positives compared to 1.1, 1.2 in the patients who are ETR negative. So authors opined that anti-ETR antibodies are associated with worse renal function during the first year of renal transplantation. Coming to anti-perlecan antibodies, anti-perlecan is a large heparan sulfate proteoglycan. It is a major component of the vessel wall. It is best known for its anti-angiogenic properties, and these anti-angiogenic properties resides in LG3 subdomain. It has been shown in this study that LG3 is a novel regulator which is associated with severe vascular rejection in the allograft, and authors saw that LG3 levels are increased in human renal transplant recipients with acute vascular rejection, and when compared it to rejection episodes with no vasculature involvement, the LG3 levels were low. Coming to anti-vimentin antibodies, it is an intermediate filament protein that is expressed within the cytosol. Experimental studies in heart transplant patients have shown accelerated acute rejection. So renal interstitial cells also constitutionally express vimentin, and that increases during rejection and ischemic injury. So when a cohort of 70 patients, out of which 40 were controls and 30 IFTA patients were studied, levels of pre-transplant anti-vimentin are elevated in patients with IFTA. Coming to anti-endothelial cell antibodies, these are the 4 anti-endothelial cell antibodies which have been studied, and they are implicated in endothelial cell activation and leukocyte extravasation. So stimulation of endothelial cell cultures in vitro also have resulted in increased production of inflammatory molecules. The severity of antibody-mediated injury when both anti-endothelial cell and HLA-DSA were detected were very high. So these are all the evidences regarding various antibodies of HLA antibodies. Now coming to the question, who should be tested for this non-HLA antibodies? It is suggested to perform pre-transplant non-HLA antibody testing and post-transplant monitoring for high-risk group of patients. Who are these high-risk group of patients? Those who are retransplanted, the patient who are of male gender, young age, that is in the children, and those with FSGS who are positive for AT1R and anti-endothelial cell antibodies prior to transplantation will be high risk and they need screening. Furthermore, testing for these non-HLA antibodies should often be performed when there is histological evidence that suggests an antibody-mediated process in absence of HLA-DSA. Coming to the methods of detection of non-HLA antibodies, AT1R and endothelial antibodies are detected by using singleplex ELISA. Singleplex ELISA has 100% specificity and 88% sensitivity. MICA antibodies are detected by single antigen Luminex assay. Anti-endothelial cell antibodies are detected by endothelial cell cross-match test, and other multiple non-HLA antibodies can be detected by multiplex solid phase assays. Considering the technical difficulties and the large variations are involved, continuous efforts to develop reliable and sensitive diagnostic tests are essential, and they are ongoing. Measuring a panel array of antibodies will provide more valuable information, and it will help to identify different risk profiles for rejection and impaired graft rather than measuring a single antigen or antibody in these case scenarios. Currently, these non-HLA antibodies can be reliably detected by solid phase assays. In this study, which I have quoted, this looked at the development and validation of multiplex non-HLA antibodies for 14 different types of non-HLA antigens that are coupled to MACplex macrospheres or via allotag. Now, coming to the treatment, the different modalities that are used for HLA antibody-induced ABMR is used for non-HLA antibodies also. The treatment as of now involves standard treatment by treating them with pulse steroids, and if they do not respond, subject them to plasmapheresis, give IVIG or administration of rituximab. Some authors have suggested that a targeted therapy is possible as we better understand the molecular pathways, how these antibodies cause rejection. AT1R, for example, AT1R specific treatment can be given in case of AT1R antibodies. It has been shown in the earlier studies that the use of losartan decreases AT1R antibody rejection episodes and results in improvement, but the subsequent studies did not support this. If there are ETAR antibodies, we can use bosentan, and if there is a combined ETAR and AT1R sparsentan molecule, whether we can be looked into. There are other antibody therapies and plasma cell therapies, including bortezomib, which can be tried in such patients. With this, I'll be coming towards the end of my presentation. The take-home message is the role of non-HLA antibodies in kidney transplantation is being progressively recognized. Non-HLA immunity is associated with poor graft survival, rejection, and chronic graft loss. It can be used as biomarkers of an ongoing immune response and as predictors of graft failure. This heralds the need for more suitable immunosuppression, and strong efforts to investigate non-HLA antibodies and their effects on graft outcome are still ongoing. So the oncology field has evolved by understanding the pathways by which it leads to tumor formation, and targeted therapy has been played in a major role in oncology. Better understanding of these rejection pathways and newer molecules may in the future may give rise to better targeted therapies, and which may result in improved graft survival for our patients.
Thank you, Dhananjay.
Thank you, Dhananjay, for that lucid presentation. And you have well described the non-HLA antibodies, and you have described the roles of various non-HLA antibodies. Also, first of all, I need to congratulate you to having managed this case well and got it to the creatinine of around 2.1 despite having an antibody-mediated rejection. You quickly resolved to do a plasmapheresis, usually because DSA was negative, but still you went ahead and did it. It was a great thought process that you had taken and found out, and you had sent MICA to IKDRC, and most of us are not aware that where MICA was done, and you got it done. And so I think the take-home message here would be those patients with antibody-mediated rejection without DSA. I think we should look for non-HLA antibodies. antibody-mediated rejection without DSA. Even the studies which you have presented, they all have mentioned whether it was DSA antibody-mediated rejection. The flowchart was like DSA positive and DSA negative. So I think we all should look at DSA negative patients where we need to further probe into whether we get any non-HLA antibodies are there or not. So over to the forum. Any questions or comments?
Yeah, thank you, Vikram. Thank you. Thank you, Dhananjay, for the excellent presentation. If there are any questions, we may take up now 1 or 2 questions also from the audience.
Chat box.
Yeah, can I comment? Can I comment, Madam? Madam?
Sure. Please do.
I think it's a very interesting case, or probably eye-opener for all the transplant physicians, because we may see quite a good number of patients who present with the typical features of the rejection, clinical and histopathological with C40 positivity, but still find that DSA is negative. So I just I'm interested to know, like, what are the percentage of these group where it is likely to have this non-HLA being positive? In what way the treatment, because treatment is almost the same, like the plasmapheresis and then escalating the baseline immunosuppression. So what is the prognosis like? Like, is it when compared to the HLA antibodies, like which is better prognosis, which is going to be like worse outcome? And like with this knowledge, like as you said, there is increasing recognition of these non-HLA antibodies being the cause of rejection. So do you have to, if it is significant and then is going to affect the outcomes and then predict the outcome, long-term outcomes as well? So is it worth doing as a screening along with the HLA, or the matching, whether to look for the non-HLA also as a screening before they start the transplantation?
Yeah,
Like
thank you for the question, madam. What I found out, madam, when we had this case and when I was speaking to the immunologist, there are many centers in India who have been doing these studies, madam. As an investigation purpose, they are not doing it as a routine thing. What I found out is these tests are also very expensive. Apart from this MICA, all the other tests are very expensive, madam. For example, if we send endothelial cell cross match, that itself costs around 80,000 rupees, madam. So that is very, very expensive. But at the same time, the percentage of the patients, according to the literature, I don't have too much of experience in these cases. But what I found out in the literature is the percentage of patients who develop these DSA negative rejections vary anywhere between 10 to 20%. This 10 to 20% is a very significant number, madam. That means we are missing a lot of rejections which are not happening because of HLA. Since HLA is being easily measured, and also because there has been, it plays a central role in the antibody mediated rejection, and the availability of these techniques which has been standardized and which is helping us to quantitate as well as correctly identify these antibodies has helped us to again and again look towards these HLA antibodies. But probably with the evolution of the techniques, because all these tests are being done on the same platform, it is just that the production or the utilization of the kits has to be done on a commercial basis so that it becomes cheaper for everyone. And also whatever sorry, I got lost. Your second question you asked me, madam, was like which what is the prognosis of these rejections?
How do they differ from the HLA?
Yes. What is the prognosis of these rejections? So if we look at 81 receptor antibodies induced rejection, that causes severely and rapid graft loss. This rapidity is much more even when compared to the presence of HLA antibodies. But others like MICA, endothelial and others are not causing so much severe manifestation from the very beginning, and they usually lead to chronic graft loss. So most of these non-HLA antibodies, they do tend to respond initially to treatment, but over a long term, these grafts will have slowly deteriorating graft function and graft loss.
Praveen, questions in the chat box, you can take that.
Yeah, Dhananjay, there is one question from Mandita. So,
Okay, this is Dr. Manisha here.
Yeah, madam.
So, can you hear me?
Yes, madam. I can.
Manisha, carry on.
Yeah, so actually excellent presentation and about these not HLA antibodies. So the problem now is that, as you said, they are expensive to do. As of now, guidelines don't exist as to what we do. Pre-transplant, should we screen for them? If we screen for them, if they are positive, what should be our approach? And should we modify the immunosuppression post-transplant? And whether we should monitor them post-transplant in case you have such a scenario where the HLA-DSA is negative. So that is one big gray area, how to clinically apply this knowledge. So you have brought out this aspect, and in this case, you were relatively successful, which is a great point. And as Dr. Swanlata pointed out, many of the therapies which work for HLA-DSAs also work here. So probably we stick to the basics and do that. Maybe for the anti-endothelial part of it, you have other endothelin receptor blockers, which may be useful, as you yourself pointed out. So this is one area about non-HLA antibodies. The other important thing is the HLA epitope mismatch. That's also important, because sometimes that HLA epitope and epilate mismatch is not picked up by the HLA DSAs, and they are also important causes of antibody mediated rejection. And we are, as of now, not able to identify them because we don't use that matchmaker and all those things as of now routinely. So these HLA DSA negative rejections can be either because of non-HLA antibodies or because of mismatches within the HLA at a level which we are not testing, a level which is more, minute level, which we are not testing. That is at the level of epitopes and epilates. So that's my comment, and congratulations for a great case.
there is one last question. There is a question from Manjusha in the chat box. Can you answer this?
Yes, madam.
Yeah, she wants to know the cost of MICA evaluation, or is it cost effective to do as a routine measure pre-transplant, and does IKDRC do this as a routine evaluation?
IKDRC does this as a routine evaluation, madam. For all patients, they are doing, because the platform of this is same. It is the same DSA Luminex assay which we use for HLA antibodies. That is the same platform that is being done. So the cost is same. In fact, whenever we are ordering for class 1 and class 2 antibodies, IKDRC gives MICA antibodies also along with it.
Okay.
So
what
you
is
said
the cost of the test? What is the cost of the test?
Madam, there it costs around 8,000 or 9,000 rupees, madam, for outsiders. But since it is an institute, most of the patients are either the state sponsored in the form of BPL or other cards. So it is done for free, madam.
Okay, thank you.
For the entire panel or for each antigen? That way?
No, madam, it is just a screening test which they do. Okay. So it is not like it doesn't come as a panel. It comes as whether it is positive or negative.
Okay.
Dhananjay, does it include other antibodies as well? Like, AECA, 81R, or is it only MICA that is given by IKDRC?
Only MICA, madam.
Okay, then if that is the question, can you just tell me, is there any algorithmic approach? Like, let's say in your case, the MICA was positive. So if MICA was negative, how do we go further with the further evaluation? As you said, these are all costly procedures that are there. How do we choose which test to be done in a sequential manner? Like, DSA negative, we have gone for MICA, but MICA is negative. Do we go for AECA? Do we go for 81RA? Any algorithmic approach is there? And the other question I have posted in the box is, knowing that it is positive in pre-transplant, as it is in IKDRC, there are a few studies from IKDRC as well. So your strategy of immunosuppression is going to change by any means. The post-transplant, if you take it as an ABMR and the management is the same. But knowing it to be pre-transplant positive, is it going to change the strategy of immunosuppression?
Right, madam. It's a very good question, madam. I am not aware of any algorithm which exists, madam, because this is, as Dr. Manisha Sahai pointed out, it is a very gray area, madam. There are no guidelines or algorithms which exist as of now which can guide us. But I have demonstrated this here. The authors have tried to develop a commercial kit where they can screen for 14 antigens together. So if such antigen kits comes, and the recommendation also says that you shouldn't look for only one non-HLA antigen.
Exactly.
It should be simultaneously tested. That is what most of these papers are suggesting.
Correct. Is this available in India, Dhananjay?
No, madam, it's not available, madam. I spoke to multiple labs. None of them are doing.
Yeah, thank you, Dhananjay. Thank you.
Dhananjay?
Thank you, the audience, for the excellent.
Dhananjay, just wanted to know, like you said, this mica and vimentin and complement fixing. So shouldn't the C4D be picked up in the ABMR? I mean, would that help? Like C4D positive, think of mica and the vimentin first rather than the other ones in non-dissociated rejection?
Yes, madam. It can be thought of that way. If it is strongly C4D positive, we can skip this 81R and anti-endothelial cells, and we can just do these other antibodies. That is that we can do, madam.
Yeah, but in your case, it was C4D negative also, though it turned out to be mica.
No, madam, C4D positive, madam.
Achha, it was C4D positive. So that's good. I mean, we can maybe reduce the expenses that way. But as I said, this is a gray area. I mean, if you go into the depths of all these things, sometimes whether the non-HLA antibodies are important or whether we are missing the HLA mismatches at a micro level, that is the question. And that is why that HLA matchmaker approach is being used in many of the Western world countries to avoid such unpredictable rejections, antibody-mediated rejections. But anyhow, great presentation.
Thank you. Thank you for the active participation. We are moving on to the next case. Thank you, everybody.
I have one question to the seniors, madam. Do you know anybody who is doing this eplet mismatching or epitope matching?
I think Dr. Shruti has, I mean, just started it. She has the, know-how, but how, and she was mentioning that she was doing it, started to do it, but it's, I think, commercially non-viable as of now. You can contact Dr. Shruti at Mumbai. She has, the know-how, and she had statistics.
Yeah.
Hello.
Thank you, madam. Thank you very much.
Sir. Yes, sir. Yes, sir. Please, sir.
Yeah, just one comment.
No problem, sir. Please do.
Dhananjay is very good presentation. So only one comment is on what is the take-home message? Like, these all tests are available to assess the sensitivity in a recipient. So basically, what are the tests which are available with us is CDC cross-match and DSA, and further tests are there. But our clinical decision should be based on the history of the both donor and recipient, and based on that, we have to have some sort of a way of simplified way of assessing the risk in the recipient. So for that, I think we should still stick on to the CDC cross-match, and if at all we find out that there are highly sensitized individual, we can go with DSA and proceed for transplant. We cannot have this sort of a battery of tests before transplant to assess the risk, because whatever we do, we may miss out something. But otherwise, the drugs which are using as immunosuppressive agents, mostly they prevented the rejections in majority of the individuals. Though we are not testing for these antibodies routinely, whatever the immunosuppression protocol we are using, like standard, like the tacrolimus, steroid, and the other mycophenolate morphine, have prevented the rejections. If at all we want, we can use induction regimens, like use of besliximab or ATG. By using this, actually, we can prevent based on the clinical assessment of the donor and recipient and a few tests, like maybe CDC. If at all we still have a doubt, we can do a DSA and differentiate these individuals of sensitivity and go ahead. I do agree that we can do this sort of a testing if at all patients unfortunately develops a rejection post-transplant and DSA is negative, we can go on doing why he developed rejection. But these as a standard test may not be recommended.
Right, sir. As you rightly pointed out, sir, right now it is not advisable to do all these tests at an individual level, sir. But people at research centers can take this to the next level, because as we understand how the rejection happens, the pathways, probably they may come with novel molecules which we can help with the patients. So that's what my aim of presenting.
Yes, very good. That take-home message is actually the thing. If at all we don't understand a rejection, we can go on doing this of investigation to understand what caused the rejection. But
yes, sir.
As of today, what are the protocol we are following of doing a CDC cross match and the high-risk individuals going for DSA will be sufficient enough to segregate the patients between sensitive recipient versus non-sensitive recipients. I think in the rejection, if it happens post-transplant, standard way of assessing the risk, if at all DSA negative or C4D negative, also some rejections are happening. There we can do this sort of antibody to understand the mechanisms and escalating the immunosuppression in that area. We can a further way of research in this area. I thank Dr. Dhananjay for bringing up this point.
Point
just
very
one
taken, sir. We
point,
just move on to the
point.
next session, please. Next
Yeah,
session.
just one point, Dr. Kiran. Just wanted to know what was the CDC in this. I mean, CDC picks up both, right? HLA, non-HLA. So what was the CDC in your case, Dhananjay?
CDC, flow cross match, and DSA Luminex class 1, class 2, all three were negative.
Okay, fine. Okay, thank you.
Thank you. Thank you. Thank you so much for the active participation. We just move on to the next session. Next case presentation by Dr. Shravan, expanded dengue syndrome for nephrologist. Dr. Shravan?
Yes, ma'am. Good evening.
Please start your presentation.
Two words about Dr. Shravan. Actually, Dr. Shravan did his MBBS from Osmania College, MD from PGI Chandigarh, and DM from JIPMER. He is very academically inclined guy, and we are very happy to be here, Dr. Shravan. Over to Shravan.
Thank you, Ali. Thank
you. Thank you, sir.
Running short of the time.
Yes, ma'am. Sure. Is my screen visible now?
No, not visible.
Yeah.
No, it's visible.
Good evening. Thank you for the entire team of the Hyderabad Nephrology Forum for giving me this opportunity to speak about an interesting case which I had encountered in my recent practice. So I'm going into the case. A 44-year-old male presented with complaints of fever and for 1 week and anorexia, malaise, myalgias for 2 days, a short duration acute febrile illness. And otherwise, no other symptoms he had. He's a known case of diabetes for 2 years. But still the baseline creatinine was not available despite he was diabetic for 2 years. And he's also a systemic hypertensive. And then with these complaints, he presented to a local center for fever, and on evaluation, his vitals were stable. He was hemodynamically stable with BP of 110/70. There was no tachycardia, and he was having a normal saturation at room air, no peripheral edema or any other rash, and all the systemic examination was normal. So on evaluation, he had a thrombocytopenia, leukopenia with platelet count of 36,000. And during the considering the hyperendemic area, we tested for dengue, and it was positive for both NS1 and IgM, and he had a renal failure with creatinine of 9.3. Then but he didn't have any other features of either dengue shock syndrome or dengue hemorrhagic fever, and urine analysis showed 2+ proteinuria with few RBCs, and the LFT was showing mild hepatitis. The other workup for the AKI and glomerulonephritis like electrophoresis, protein electrophoresis, ANCA serology, and urine culture was negative. Blood cultures, malaria serology, and were also normal. The fundus did not show any evidence of retinopathy, and ultrasound showed normal sized kidneys. So considering his uremic symptoms and high azotemia, we given him 2 sessions of HD, and his urine output gradually improved. And there was some problems during the dialysis catheter insertion, that after the catheter insertion, he had a persistent oozing of blood from the exit side, but it resolved with the SDAP transfusion and after HD over a period of 24 to 36 hours. And after 2 sessions of HD, his urine output gradually resolved, and over the next 10 to 15 days, his creatinine had come to a baseline of 0.9. So we made a diagnosis of expanded dengue syndrome with severe AKI, which was resolved in the acute phase with diabetes, hypertension, and thrombocytopenia. So I'll go into the discussion. So around 2.5 billion people in 129 countries live in endemic tropical and subtropical regions with high risk for AKI, and around 105 million people are infected with dengue every year. The illness can range from subclinical illness like flu-like symptoms, but still a small subset of patients develop a severe form of the disease with severe bleeding, organ involvement, and plasma leakage with reduced blood volume. And it can be classified as per the WHO as dengue without warning signs, with warning signs, and severe dengue. So this is the WHO 2009 revised dengue classification, basically into three categories: dengue with warning sign, and without warning sign, and severe dengue. For a probable dengue, the criteria is that they are living in a or travel to an endemic area, and fever with any of the two of the following, like nausea, vomiting, rash, aches, pains, and tourniquet test is considered as a very screening test to detect for dengue fever, and leukopenia or any other warning sign like abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, and mucosal bleed, lethargy, restlessness, liver enlargement, and increase in hematocrit with rapid decrease in platelet count. And for the severe dengue, it is the severe plasma leakage leading to the shock and fluid accumulation with respiratory distress, and any other severe bleeding or organ involvement as assessed by a severe transaminitis and altered sensorium, and any myocarditis or other major organ involvement. So the dengue virus infection can be either asymptomatic. In majority of the cases it is asymptomatic, and it can, or if it is symptomatic, it can be present as an undifferentiated fever, or as discussed, like a dengue fever, dengue hemorrhagic fever, or the newer as per the WHO 2012, it had included this new category called as the expanded dengue syndrome, or an isolated organopathy, which is a very unusual manifestation. So this is the course. It is appears to be a triphasic illness with three phases: initial febrile phase, then followed by a critical phase. When the patient is becoming defervescent, they develop this critical phase with organ impairment, shock, bleeding manifestation, and if they get through this phase, then they have a recovery. So coming to this expanded dengue syndrome, this is a coined by the WHO in 2012 to describe patients who do not fit into either the severe manifestations of dengue, like dengue hemorrhagic fever or dengue shock, but they have a severe involvement of the other vital organ systems like cardiovascular system, neurological system, kidneys, GIT, or the hematological system. And a certain subset of patients such as pregnant women, infants, elderly groups, and patients with coronary artery disease, hemoglobinopathies, and immunocompromised individuals are particularly susceptible to develop this expanded dengue syndrome. So this is the figure showing the spectrum of the expanded dengue syndrome with the various organs involved, like in the neurological, it can present with encephalopathy, encephalitis, aseptic meningitis, intracranial hemorrhages, and thrombosis, neuropathies, GB syndrome, and in the spinal cord, it can cause myelitis. Then gastro and hepatic involvement like hepatitis, fulminant hepatic failure, acalculous cholecystitis, pancreatitis, febrile diarrhea, and parotitis. In the renal, it can present like as our case AKI, glomerulonephritis, electrolyte disturbances, nephrotic range proteinuria, and hemolytic uremic syndrome. Then in cardiac, it can cause myocarditis and conduction abnormalities and bradycardia. Respiratory, it can present with ARDS and pulmonary hemorrhage and musculoskeletal like rhabdomyolysis and myositis. And in the lymphoreticular, it can cause a splenic rupture and lymph node infarction. So the pathogenesis exactly is not clear, but many of the studies, the plausible hypothesis has been derived from the autopsy studies, which show the liver, spleen, and lymph nodes are the major target of involvement for this dengue virus. But still, the recent advances on the atypical manifestations show other organ involvement also, like kidney, lung, heart, and central nervous system. And all the data, autopsy data, show the presence of hemorrhage, edema, and inflammatory infiltrates in these organs. So there is a broad spectrum of the renal involvement in the dengue patient, as we discussed, these include the electrolyte imbalances, elevation of the creatinine, then AKI, acute tubular necrosis, HUS, proteinuria, glomerulopathy, and nephrotic syndrome, and IgA nephropathy has also been discussed, but described, but it appears to be more like a post-infectious IgA because they have done one patient biopsy. Initially, there was an IgA deposition, and after 6 weeks, when they did the repeat biopsy, the IgA deposits had disappeared. So it appeared to be more of a post-infectious IgA glomerulonephritis. So the pathogenesis of this dengue-induced renal disease is basically can be broadly into two categories: either direct action by the virus or other indirect actions like hemodynamic instability or immune-mediated phenomena leading to rhabdomyolysis, hemolysis, or acute glomerular injury. There is also a direct invasion of the kidney, and the hemodynamic fluctuations during the course of the dengue are also very important in the kidney involvement. And in some subset of patients, low levels of C3 are also being reported, especially with shock, sepsis, hemolysis, and rhabdomyolysis. And autoimmunity induced by molecular mimicry has also been hypothesized, and some patients have been known to develop lupus nephritis also after dengue. So, as we discussed, among hospitalized patients with severe dengue, around 3.3% to 4.8% can develop the AKI, of which around 14% require the dialysis. And as far as the risk factors for AKI in dengue are considered, they include the advanced age, male gender, possibly related to the testosterone enhancing the inflammation, and then obesity, hemorrhagic fever, rhabdomyolysis, multiple organ dysfunction, other comorbidities like diabetes, any concomitant bacterial infection, delay in hospital consultation, and use of any nephrotoxic drugs like NSAIDs and aminoglycosides. So other glomerulonephritis have also been described with dengue. These include the FSGS, MPGN, membranous nephropathy, IgA, MCD, post-immune, and crescentic. The basic pathogenesis is the deposition of the antigen-antibody complex, or there is a in situ antigen-antibody deposition, cell-mediated injury, autoimmunity, humoral, and other inflammatory mediators. So some renal biopsy data has shown deposits of the IgG, IgM, and C3 along with the dense spherical particles in some cases. And there are also the low levels of C3 and dengue viral antigens have also been demonstrated in the renal tubular epithelial cells. And as far as the dengue infection in transplant patients is considered, so because it generally follows a benign course, but some subset of patients can develop a severe dengue hemorrhagic fever and dengue shock syndrome also. So interestingly, some patients on cyclosporin containing regimen had a less severe, because the cyclosporin has been demonstrated to have a anti-flaviviral properties. And similarly, MMF may increase the disease severity, and it needs de-escalation, particularly in patients with refractory cytopenias. And since the relationship of dengue with poor outcomes among kidney transplant recipients is not well established, it is also advised to consider screening for dengue viral infection before transplantation, particularly in epidemics and dengue endemic areas. And as far as the treatment is considered, it is supportive with fluids and electrolytes, and frequent volume status assessment and judicious fluid administration to prevent overload are mandatory. Crystalloids are still the fluid of choice in dengue infection, but colloids can be considered in patients with refractory shock. And if the in a hemodynamically unstable patient with severe AKI, the CRRT is the best treatment for wherever it is available. But PD is documented to be associated with worse outcomes in one study from Sri Lanka. So to conclude, we present one atypical presentation of dengue with severe AKI and complete recovery in acute phase. He did not have any manifestations of the other manifestations of severe dengue hemorrhagic fever or dengue shock syndrome. And the renal manifestations are generally mild, but some patients like this can develop more severe injury leading to AKI. So the WHO has coined the term this expanded dengue syndrome to designate those cases that do not fall into the dengue shock syndrome or hemorrhagic fever, but they have the isolated severe organ involvement. So these, we should be mindful of these unusual features so that we can suspect dengue early, especially during the ongoing epidemics, and particularly patients with AKI deserve a careful and long-term medical follow-up, given that severe AKI CK is and associated with the increased risk of CKD in the long term. Thank you.
Thank you, Shravan. Thank you. You presented very well, and then you could convey the message that dengue should be included in the differential diagnosis basket of any AKI nowadays. Now the discussion is open for the House.
Yeah, Shravan, it was a very nice presentation. In fact, as you have mentioned, now we are seeing, of it, you are seeing a lot of patients who present with the non-specific symptoms, particularly in transplant patients. Recently, we have seen a lot of transplant patients just come with graft dysfunction. And as a part of a routine, particularly when we evaluate, they are found to have this dengue IgM positivity. So, I mean, that's about our experience. And the second thing I just wanted to know was, like you said, there is a varied presentation of these, organ involvement, particularly with respect to kidney. They can involve the, present as ATN or the glomerular disease, including IgA nephropathy or, autoimmune molecular mimicry. So, when do you have a role in biopsying this patient? If so, when do you do a biopsy, and is it going to change the treatment and the long-term outcomes?
Biopsy data is very limited, ma'am, actually, because they have a thrombocytopenia, and many patients do not be willing to be undergoing a biopsy, considering it is an invasive procedure. So the data which was available, we have seen it is showing the deposition of C3 and IgM, IgG, and some electron microscopy also showing the dengue viral antigens in the renal tubular epithelial cells. So as far as my knowledge, I am aware of this much.
Yeah, dengue can present in any ways. Recently, we had a case of dengue-associated renal artery thrombosis. So dengue is considered to be a greatest deceiver. Anyway, Shravan, thank you so much. We expect more contributions from you for Hyderabad Nephrology Forum. If any further questions are not there, we'll move on to next session. If not, anyone can raise their questions. So shall we move ahead with next presentation, madam?
Okay. Thank you, Shravan. Thank you for the lucid presentation and a very interesting case. Thank you very much for the inputs also. Thank you. We move on to the next session. To chair this session, may I invite Dr. Manjusha, Professor and HOD, Department of Nephrology, Gandhi Medical College. Hello, Manjusha.
Yeah. Thanks, Kiran. Thanks so much. So without much ado, I think I can call upon Dr. Tausif to share the case details. Tausif, please.
Good evening. Another chairperson as well, Dr. Sridhar. Yes,
Dr. Sridhar. Hello, Sridhar.
Yeah, good evening, madam. Yeah, good evening.
Welcome to the forum. Kindly do the sharing, please.
Okay, madam.
My slides are visible.
Yes, Tausif.
Tausif, please carry on.
Good evening, all the respected seniors. Today I am presenting an unusual case of infantile nephrotic syndrome. Coming to the history, my patient, 9-month male child, born of 3rd-degree consanguineous marriage, admitted with complaint of generalized body swelling since 15 days, decreased urine output since 15 days. Patient started to develop periorbital puffiness, followed by bilateral pedal edema, which gradually leads to abdominal distension and generalized anasarca. There is no past history of similar illness. There is no history of hospitalization. Family history, born of 3rd-degree consanguineous marriage, third by birth order, no history of similar illness in the family. Baby is full term, born by LSCS, indication was previous LSCS, birth weight was not known. Baby cried immediately after birth. Developmental history is normal as per age. Baby was not immunized for any of the vaccination. Coming to the examination, baby is conscious, euthermic, heart rate was 106 per minute, blood pressure was 100 by 60 millimeter of mercury between 95 to 99 centile, no pallor icterus, sinuses clubbing, lymphadenopathy. Weight is 7 kg, between 3rd to 50 centile, length is 64 centimeter, between 3rd to 50 centile, head circumference was 44 centimeter, which was between 3rd to 50 centile, body surface area is 0.35 meters square. There is no dysmorphic faces or no syndromic features are present in the baby. Coming to the systemic examination, per abdomen is soft, non-tender, no organomegaly is present. The respiratory examination, No adventitious sounds are present. Cardiovascular system S1, S2 was heard. No murmur. Apex in the fourth intercostal space, 2 cm medial to mid clavicular line. Hyperdynamic impulse was there. CNS examination, baby is conscious, playful, and no focal neurological deficit is present. The lab parameter, on admission, the child has blood urea of 95, serum creatine of 1.6, sodium is 136, potassium 6.5, chloride is total protein was 3.4, and albumin is 1.6. Spot PCR is 40, which was weekly followed up. Spot PCR was gradually decreased to 4 at the end of 6 weeks. Serum creatine gradually decreased to 0.81 at the end of 6 weeks. Total cholesterol on admission was 442 milligram per deciliter. Triglyceride was 939. HDL was 29. LDL was 368 milligram per deciliter. At the end of 6 weeks, total cholesterol was 124. Triglyceride was 212. HDL was 32 and LDL was 188. Hemoglobin was 9. Total leukocyte count was 9,400. Platelet count was 1.52 lakh. CUV was suggestive of specific gravity was 1.025. Albumin was 1 plus. Sugar was nil. RBC 1 to 2 RBC was present. 10 to 12 RBC pulses are present in the urine. Ultrasound abdomen was done, which was suggestive. Right kidney is 6.7 into 3.5 centimeter. Left kidney was 6.6 into 3.7 centimeter. Bilateral kidney looks mildly edematous and echogenic. Course in the hospital stay. Child was initiated on renal replacement therapy in the form of peritoneal dialysis because of in view of polyuria, deranged RFT, and metabolic acidosis. PD was continued for 5 days. Urine output improved. Hence, PD was removed. As the child was having hypertension, he was started on antihypertensive medication and he was maintaining on 4 antihypertensive medication BP less than 90% time. Child was also given injection of human albumin 20% during the course of hospital stay, and renal biopsy was planned after the stabilization. Renal biopsy was done after stabilization. The microscopic description is suggestive of serial section study shows a core of renal cortex with up to 12 glomeruli and 2 arteries. 2 glomeruli appear involuted, the rest of the glomeruli appear normal. There is no increase in cellularity, basement membrane changes, or segmental lesions. 1 to 2 glomeruli appear infantile. Tubules are closely packed. There is no evidence of tubular atrophy. There is tubular injury, focal flattening, and denudation of lining epithelium. Occasional tubules are dilated and show hyaline granular cast. Foci of luminal calcifications are seen. The interstitium and blood vessels appear normal. IF studies show 7 glomeruli, 3 are sclerosed. There are insignificant immune deposits of IgM in the glomerular duct. The proximal tubular cells show significant granular positivity for IgG and C3c. The diagnosis was biopsy shows unremarkable glomerular and mild tubular injury. Features are consistent with minimal change disease. Further, we proceed with the electron microscopy. Electron microscopy was done. The tissue was reprocessed for transmission electron microscopy and ultrathin section scan with the uranyl acetate and lead etc. 1 glomerulus and accompanying tubular interstitiums were analyzed. Paraffin artifacts were prominent in limiting evaluation. Focal significant effacement of food process of visceral epithelial cells is noted, which is about 60%. There is no definite electron dense organized deposits or basement membrane laminations are observed. Areas of GBM wrinkling and subendothelial rare fractions are seen. Few tubules shows electron-nuisance vacuolar inclusion in cytoplasm. Extraglomerular electron-dense deposits are not seen. The impression was there is a focal significant effacement of visceral epithelial cell food process, 60%. No evidence of electron-dense deposits in mesangial areas or glomerular basement membranes. The child was started on oral steroid 2 mg per kg after immunization as per age. Child did not achieve the remission. The child was continued on antihypertensive medication and albumin. The parents were counseled for the genetic analysis, but initially they were not willing, and steroid is continued for the 6 weeks. Genetic analysis is done at the end of 6 weeks. Genetic analysis report was done. The results are variant of uncertain significance related to the given phenotype was detected. In this, the gene coenzyme Q2 mutation was found. Location was exon 1. There is a homozygous zygosity is there. The disease's primary coenzyme Q10 deficiency was present. Inheritance is autosomal recessive. The classification is uncertain significance. Coming to the variant description, of homozygous missense mutation in the exon 1 of the coenzyme Q2 gene that result in the amino acid substitution of lysine for methionine at codon 128 was detected. The variant, the parameter variant has not been reported in the 1000 genome and database and has a minor allele frequency of 0.003% in their internal database. This primary coenzyme Q10 deficiency is caused by the homozygous or compound heterozygous mutation in CoQ10 gene. Disorder has been associated with 4 major phenotypes, but molecular basis has not been determined in most of the patients with disorders, and there are no clear genotype-phenotype correlation. The phenotype include encephalomyopathic form with seizures and ataxia, multisystem infantile form with encephalopathy, cardiomyopathy and renal failure, a predominantly cerebellar form with ataxia and cerebellar atrophy, and leak syndrome with growth retardation. The correct diagnosis is important because some of the patients may show a favorable response to the coenzyme Q10 treatment. The child was started on coenzyme Q10 supplements with a dose of 10 mg per kg. Unfortunately, the patient left hospital after a few days against the medical advice of starting the supplements. So coming to the diagnosis in our case is an infantile nephrotic syndrome, steroid resistance with minimal change disease with coenzyme Q2 nephropathy because of coenzyme Q2 mutation. So coming to the nephrotic syndrome, as per KDO20 guidelines, nephrotic range proteinuria are either hypoalbuminemia or edema is classified as nephrotic syndrome. Nephrotic range proteinuria of 40 mg per meter square per hour or more than 1 gram per meter square per day, or spot UPCR of more than 2 mg per milligram, hypoalbuminemia and edema by ISPN guidelines. The congenital nephrotic syndrome is characterized by the nephrotic range proteinuria and edema that manifest in utero or during the first 3 months of life. If the nephrotic syndrome manifests after 3 months up to the 1 year of age, it is called as an infantile nephrotic syndrome. So coming to the steroid-sensitive nephrotic syndrome, steroid-resistant nephrotic syndrome. Steroid-sensitive nephrotic syndrome is defined as complete remission after 4 weeks of prednisolone or prednisolone standard dose. Or steroid-resistant nephrotic syndrome defined as lack of complete remission at 4 weeks of therapy with daily prednisone or prednisolone standard dose. This is the treatment algorithm for the nephrotic syndrome newly nephrotic child as per KDO 2020 guidelines. In this guideline, they have mentioned if the child is less than 12 years of age, there is no syndromic features of family history, we have to start the steroid. If the patient is a complete responder, then we have to continue with the corticosteroid for 8 to 12 weeks, depending upon the frequent, infrequent, or steroid dependency, the treatment will be given. If there is no response to steroid for 4 or 6 weeks, then we have to go ahead with the genetic testing, kidney biopsy, CNI, RAS inhibitors. So coming to the indication for kidney biopsy, children presenting with nephrotic syndrome more than 12 years of age, steroid-resistant nephrotic syndrome or subsequent failure to respond to steroid in steroid-sensitive nephrotic syndrome, that is secondary steroid resistant nephrotic syndrome, high index of suspicion of for a different underlying pathology like microscopic hematuria, extra kidney symptoms, or hypocomplementemia, or there is at onset kidney failure not related to hypovolemia, subsequently decreasing kidney function in children receiving CNIs or prolonged exposure to CNI is an indication for biopsy. Coming to the genetic testing, as per KDIGO, they have mentioned steroid-resistant nephrotic syndrome, congenital or infantile form of nephrotic syndrome that is less than 1 year of age, nephrotic syndrome associated with the syndromic features or family history of steroid-resistant nephrotic syndrome or FSGS is an indication for genetic testing. This is the IPNA 2020 guideline for steroid-resistant nephrotic syndrome. In that, they have elaborated the need for genetic testing in SRNS patient. It may provide the patient with and families with an unequivocal diagnosis may uncover a form of SRNS that is amenable to treatment, that is coenzyme Q10 deficiency, may avoid the necessity of a renal biopsy and allow early weaning for the immunosuppressive therapy, may allow the accurate, well-informed genetic counseling, including a risk of recurrence post-transplantation. It may allow the appropriate diagnosis and management of extrarenal manifestation with whole exome sequencing technique. 10 to 30% of children are not diagnosed with a monogenic disease. Mutation in NPHS2, WT1, and NPHS1 are the most common genetic SRNS causes in European patients, which accounts for 42, 16, and 13% of the genetic cases, respectively. The mutation in NPHS2 gene causes SRNS in 20 to 30% of sporadic Caucasian cases. The likelihood of identifying a positive mutation is inversely related to age at the disease onset and is increased with either a positive family history or the presence of extrarenal manifestation. These are the certain genes which are responsible for steroid-resistant nephrotic syndrome, among which coenzyme is one of the gene which leads to the SRNS. It's a mitochondrial type of disease, which may present as a multi-system disorder or isolated nephropathy. So coming to the clinical presentation of coenzyme Q10 deficiency syndrome, as we know, this is the case of coenzyme Q2 nephropathy, which will lead to the deficiency of coenzyme Q10. So what is coenzyme Q10 deficiency? In coenzyme Q2 deficiency, which predominantly presents in childhood, it's an autosomal recessive mitochondrial disorder caused by deficiency of CoQ10. It's a lipid-like molecule involved in multiple cellular processes, including the mitochondrial respiratory chain activity. CoQ10 deficiency is clinically and genetically heterogeneous syndrome, which has been associated with 5 major clinical phenotypes. First is a encephalomyopathy, severe infantile multisystemic disease, nephropathy, cerebellar ataxia, or isolated myopathy. This is the CoQ10 biosynthetic pathway. As we know, as we can see in this diagram, there are total 10 genes are involved in this coenzyme Q10 pathway, of which one of the gene is coenzyme Q2 gene. If this gene is affected or there is a mutation in this gene, this subsequent formation of CoQ10 will not happen in the mitochondria, and the child will be presenting with a different multisystem or isolated nephropathy syndrome. So mitochondrial cytopathies includes a heterogeneous group of disease with impaired oxidative phosphorylation, who did 144 patients from 95 families with a primary CoQ10 deficiency and glomerular involvement have been described based on mutation PDSS1, PDSS2, CoQ2, CoQ6, CoQ8b, ADCK4. Currently, mutation in 10 different genes involved in the CoQ10 pathway have been reported. That is PDSS1, SS2, CoQ2, 4, 5, 6, 7, 8, ADCK4, ADCK4, ADCK3, CoQ8b, and ADCK4 and coenzyme Q9. So there is a variable degrees of CoQ2 deficiency, which leads to the defect in ATP synthesis and oxidative stress. If the severe CoQ2 deficiency, then the enzyme will be less than 20% of the normal, which leads to the significant bioenergetic defects without the oxidative stress. In intermediate CoQ10 deficiency, 30 to 40% of the normal enzyme will be present, which leads to moderate bioenergetic defect. There are milder or severe presentation in this disease. Severe presentation will lead to the CoQ2 mutation, which harbors the 2 alleles. In milder phenotype, the patient may present with the isolated nephrotic syndrome, at least one allele that allows the significant residual CoQ10 biosynthesis for ROS protection will be there. So coming to the treatment, oral administration of CoQ10 is the treatment strategy for affected individual with a CoQ10 deficiency. Different formulation of CoQ10s are available. Oxidase form is ubiquinone, reduced form is ubiquinol, analogs are abidinone. In the literature, the daily dose of CoQ10 is ranges from 5 to 100 milligram per kg. These are the certain formulations are available in the market for coenzyme Q supplementation. So in the literature, as we go through the literature, the clinical characteristics of the patient in CoQ10 deficiency by different genes we found. In the CoQ2 gene is affected, like CoQ2 nephropathy. It has been reported in the 28 patients from 23 families. Median age of onset is 9 months. Reported extrarenal symptoms are 60 among the 68% of the patient. Kidney failure of the patient present in the 63% of the patient. Median age at kidney failure was 2.1 year. Time to kidney failure was 5 months. The histopathology in the patient was most common is FSGS in 69%. CoQ2 supplementation was given to the 65% of the patient. The dosing range was 5 to 60 milligram per kg per day. After the treatment, it has been observed that the improvement in the neurological condition observed in 14% of the patient, but 29% of the patient deteriorated neurologically. The kidney symptoms improved in 43% of the patient. There is no effect in kidney symptoms observed in 29% of the patients. So coming to the certain case reports, this CoQ2 nephropathy, a treatable cause of nephrotic syndrome in children was reported by Mitchell Starr. In the case report, in the 3 pediatric patients with CoQ2 variants presenting with nephrotic syndrome, the 2 of the 3 patients treated with CoQ2 supplementation, the nephrotic syndrome resolved, and at follow-up, both have normal renal function and stable proteinuria. So to conclude that the CoQ2 nephropathy should be suspected in patients presenting with nephrotic syndrome, although the less common due to the more common genes are NPHS1, NPHS2, and WT1. This is the article in JSN, CoQ2 nephropathy newly described inherited mitochondriopathy with primary renal involvement. They have observed the two patients. The first patient presented with steroid-resistant nephrotic syndrome at the age of 18 months as a result of collapsing glomerulopathy with no extra-renal symptoms. The second patient presented at 5 days of life with oliguria, had severe extracapillary proliferation on renal biopsy, rapidly developed end-stage renal disease, and died at the age of 6 months after a course complicated by progressive epileptic encephalopathy. In conclusion, it suggested that inherited CoQ2 mutation causes a primary glomerular disease with renal lesion that vary in severity and are not necessarily associated with neurological signs. This is another case report from China. CoQ2 mutation associated isolated nephropathy in two siblings from a Chinese pedigree. The two cases harboring CoQ2 compound heterozygous mutation presented with isolated sRNS with a renal pathology of FSGS and a large quantity of mitochondria with normal contour accumulated within the podocyte. CoQ10 was efficacy in eliminating the proteinuria in these cases. This is the study from USA. This mouse model of CoQ deficiency. In that, CoQ supplementation risks the nephrotic syndrome through the normalization of H2S oxidation pathway. They have showed that mouse model of CoQ deficiencies, which was associated with nephrotic syndrome, long-term supplementation of CoQ10 prevents the kidney failure by rescuing the defect of sulfide oxidation and ameliorating the oxidative stress, despite only incomplete normalization of kidney CoQ level and lack of rescue CoQ-dependent respiratory enzyme activities. So, as we know, in the infantile nephrotic syndrome, we have either we have to go for the biopsy or the genetic testing, but in the resource poor setting, the cost of genetic testing is more. So we have to approach the mutational screening in a proper way. So if the patient present with the isolated sRNAs, the next genome sequence is next generation sequencing technology, if it is accessible or affordable, then gene panel, whole gene panel, we can, if the patient can afford, we can do the whole gene panel, which involve from NPHS1 to WT1, LAMP2, PLC1, TRP6, and all the genes. If the patient is limited to sequential testing, we have to see the onset of nephrotic syndrome. If it is a congenital nephrotic syndrome, then targeted gene testing we can do, like NPHS1, 2, WT1, LAMP2, PLC1, and LMX1B. If the patient is presenting in the infantile childhood range, then the genes will be different. If the patient is having adolescent onset, then NPHS2, TRBC6, INF2, SCTN4, ADCK4, and WT1 screening will be done. If we have done the biopsy and biopsy is suggestive of isolated DMS, then we can directly go for the testing of WT1, PLC1, and LAMP2 screening. Based on the ethnicity, if the patient is from Chinese population, then we can directly go for the ADCK4 screening. If the patient is from African descent, we can go for the APOL genotyping. So coming to the take-home message, timely utilization of genetic testing in sRNS will improve the outcome. Timely identification of CoQ10 mutation will yield effective outcome. CoQ2 nephropathy, that is CoQ2 deficiency, is only treatable cause of nephrotic syndrome. Thank you.
Yeah, thanks, Tausif. I mean, definitely in treating this case, we had certain challenges. First thing was the child was not immunized before we had thought about starting any steroid therapy. So we had to wait for the immunization and then only start with the steroid therapy and then look into whether it's a steroid resistant nephrotic syndrome and all this. So even though the indications are clear about the genetic testing in our setting, straight away going for genetic testing may not be cost effective. That is the reason why we had to go ahead with a biopsy. Even for biopsy, we needed a good stabilization because patient had hypertension, needing antihypertensives and all this. So having a biopsy, though it has suggested that it was MCD and then effacement was 60%, and then electron microscopy, yeah, showed 60% effacement. The diagnosis may be a conundrum of MCD and FSGS. The interesting thing is in the CoQ2 mutation causing a CoQ10 deficiency, it is supposed to be an FSGS pattern, which is not seen in this case, but definitely an unsampled FSGS could still be there. And electron microscopy is supposed to be showing certain mitochondria, which is not seen in this case. Maybe it may not be mandatory that the mitochondria could have been reported in the electron microscopy, but these are two salient things which were reported in the literature. But having said that, though the report had come as VUS, like uncertain significance, but in the background of presentation of the clinical presentation of having a nephrotic syndrome as a presentation and SRNS, we thought probably the child will fit into these CoQ2 nephropathy with a positive mutation, secondary to CoQ10 deficiency. Hence, we started on CoQ10 supplements. Of course, though the dose has ranged in the literature from 5 to 100, and few reports have suggested it to be at 30 milligram. Yes, we started with 10 milligram. Unfortunately, patient left on medical advice. But whatever we had, the latest inputs were patient did not improve and subsequently expired because of some other reason. This patient did not have any syndromic, syndromic manifestations at the outset. It was only isolated nephropathy. So the interesting thing in this patient was like SRNS in an infantile nephrotic syndrome, non-syndromic presentation, biopsy showing MCD, genetic testing showing a CoQ2 mutation, which is positive. What literature highlights is this is the only SRNS which is treatable in an effective way, and it is the whole nephrotic range proteinuria and the renal dysfunction which exists is definitely reversible with this treatment. Though earlier this entity was not given significance, of late over the past few years, this entity is being recognized in the nephrology literature even as an isolated nephropathy. So this is what we thought we should bring about. Identifying this at right time probably will give a good result, though in our case it was little late. Patient had stayed for longer time because of so many challenges that we had in finally coming out at the diagnosis.
Dr. Sridhar?
Yeah, madam. No comments, madam. But it is a good presentation and it's a rare case. And sometimes, like if we diagnose early and only this abnormal presentation in this patient is, there are no other syndromic manifestation, only presenting with nephrotic without most of the mitochondriopathies. Generally, they have other associated symptoms also.
Correct.
In this, that is not there. That is the only odd feature in this patient.
Yes, Sridhar, you rightly said. Actually, when we look at the phenotypes, they said encephalomyopathy, isolated myopathy, all this. So we were also wondering, because not having a syndromic presentation, are we right in diagnosing? So when we looked in the literature,
that is only.
Isolated nephropathy is also reported in few of the cases, and reversibility is also noted in them, because in syndromic manifestations, when the muscle this thing or enkephalon is involved, probably not much of improvement may be noted in such scenario. But isolated nephropathy, if it is there, a reversal of nephrotic range proteinuria has been reported. So we were also in a dilemma, but the literature has supported us in taking forward with the diagnosis of relating the cause with the outcome of nephropathy.
Any other comments from
Any questions from audience?
Yeah, can I comment, please?
Yes, Swanlata, go ahead.
Yeah, I mean, it was a very excellent case and well managed, and diagnosed also. Time diagnosis was done. So like I have few doubts, queries, like like as you said, it is a congenital nephrotic syndrome, and initially, as far as I heard, he also underwent renal replacement therapy. He had a kidney failure and underwent renal replacement therapy. So subsequently, was it like completely recovered, and biopsy did not show any of the chronicity changes, I believe, as per whatever your statement is. And like, how do you suspect, like, routinely conventional, when you look at congenital nephrotic syndrome, the whatever Sanger sequence we ask for is NPHS1 and the conventional thing. So like and if it's negative, then only you go for a whole exome sequencing and look for the the other rare the genomic abnormalities and all those things. So how did you diagnose? How did you pick up this? And the second thing is like management part, like is steroids also, because this is only one congenital nephrotic syndrome which is curable. So when we start the coenzyme 10, as you said, so is it necessary to them to expose the steroids also? And what is the long-term outcome? Like, like do they remain non-nephrotic or normal with normal kidney function throughout their lifetime, and they have a normal lifespan? So what is the long-term? They have to be on lifelong coenzyme 10 supplementation.
Okay. First thing is, this is infantile nephrotic syndrome, not a congenital nephrotic syndrome, because the patient presented at 9 months of age. That's one. The second thing is, as you had asked, the suspicion, there is a dilemma whether to go in for genetic testing first or to go ahead with a biopsy. See, once we diagnose a patient to be having a steroid resistant nephrotic syndrome after a particular treatment as per the guidelines, we are in a dilemma whether we have to do the biopsy genetic testing. That is the reason why we had projected that slide in one of the publications that was there, which suggests that if the cost is good for you, probably you can go ahead with the NGS sequencing, which will identify all the genes. But if it is not cost effective, since you have already done a biopsy, based on your biopsy finding, please ask for certain genes which are of relevance. I think Tausif has projected that slide, because if in DMS, you can ask for 3 genes. If it is infantile at childhood, you ask for few genes, so that your cost comes down. In this case, we have done NGS. It was more specific than NGS. It was targeted gene screening that was done. So which has identified this COQ2 mutation. So it was an NGS only it was done, which costed about, I think, 15 to 18,000 for us, which was a phenomenal cost for a patient in our setup. But yet we had convinced the parents. The other question that you have asked is the long-term outcome. See, this is a treatable nephrotic syndrome of SRNS. So if you start CoQ10 supplements, apparently it's supposed to be reversing from nephrotic point of view as well as from renal failure point of view. The long-term outcome of this is not mentioned in the literature, because the literature is existing only for the past few years. Maybe in the future, we will be able to look at the long-term outcomes of such scenario of CoQ10 deficiency. The third entity that you had asked was the biopsy histopathology correlation. This patient had renal insufficiency at the outset. During the course of hospitalization, patient went up to 2 creatinine, 3 creatinine. He was anuric. Sometimes, despite the improvement with the albumin, there was no improvement in urine output. We had done PD. That was the indication. In fact, metabolic acidosis was also there. So we had gone ahead, but PD transiently for about 2 times. Of course, there was reversal of this renal insufficiency with the supportive treatment that we had given. And biopsy correlation that you had asked, we also had a doubt about this, but definitely there was a mild tubular injury which was present in the biopsy report. Of course, the other ischemic part of it definitely might not have been found out on biopsy, but we take it as probably mild amount of tubular injury was there in the biopsy, which had a correlate with the renal insufficiency. So these are the things. The other thing which we were interested in is, when we have such an isolated case, doing the analysis in the family members as well could have supported our diagnosis in a more stronger way. But the struggled with a single case for the cost matters. I don't think we could have forced the parents to undergo the genetic testing to prove or disprove whether it is running in the family or not. So these were the definitive, gray areas when we had managed the case. Probably we would have thought, supplementing the patient with CoQ10 would have given us an improvement, but unfortunately, with a longer stay in the hospital, with so much of burden on them, they had left against medical advice, and then patient expired due to some other unknown reason after a later follow-up.
Yeah, thank you, Manjusha. I was just considering, like you said, the screening of the family members. Once we identify, this is a specific gene mutation, it's easier to screen the family because we have that
exactly.
So
exactly. But coming from a certain background, low socioeconomic status, pushing them to get a test of 20,000 was a Herculean task for us. And then after that, convincing the parents to undergo, other siblings also to undergo the test, definitely would be very, very difficult for us. But yes, that is one possibility that we had in mind.
Yeah, moderators, any more questions?
Yeah. Manjusha, that was an excellent case, actually very rare case. We have seen so many congenital nephrotic syndromes and infantile nephrotic syndromes as well in our setup. But then this is a case which we haven't seen actually. Congratulations, very well managed. And
interesting thing is, Kiran, like it is treatable. This also we learned over a period of time. Like, it's a treatable
exactly.
of SRNS, generally we think that as Swanlata has asked, steroid should be continued. No, alternative immunosuppression will definitely not think once we know that it is a treatable and treatment is only CoQ10. So that way we are inclined to look into such etiologies because it's a treatable entity.
Yes. Unfortunately, we lost the child. Hope he would have improved. Few comments from Manisha.
So Kiran, if you remember, recently we had one of, CoQ10. So, I mean, that patient was also started on the same therapy. Now, only thing is that interpretation of the genetic reports is a bit tricky because according to the classification, like variant of unknown significance, we do not know. The other picture, as Manjusha said, fits into and is consistent with the diagnosis. But again, I mean, sometimes that VUS is a bit tricky thing because whether we can attribute everything to that mutation, because as of now it has been labeled as a variation of uncertain significance. So there are guidelines how to interpret these genetic reports, and I mean it would be good if we take the opinion of a genetic expert as well, because now we are doing more and more genetic testing for congenital nephrotic syndromes, infantile nephrotic syndromes, and we are understanding a lot better. So sometimes, I mean, the mutation may be there, but again, you have 5 different classes. Out of that, 2 you have pakka significance that it is related to that. Whereas in others, sometimes we have to explore more. And as Manjusha said here, probably we were not able to because of the cost constraints and all that. So that is an issue. So another important point for the postgraduates I would like to make is this was a genetic cause. That's right. But whenever you have congenital nephrotic syndrome or infantile nephrotic syndrome, always look for the dysmorphism, always look for the gonads, which I think Tosi did mention. The other important thing is to rule out the congenital infections, the torch infections. So not in this setting, but always that should be mentioned because many of the nephrotic syndromes occurring in infants related to torch are reversible with specific therapy without putting them on immunosuppression. So don't ever forget that in such a setting where you have either congenital or infantile nephrotic syndrome, but otherwise it is presentation and genetics very important, especially in congenital as well as infantile nephrotic syndrome. Always do. Thank you.
Yes, Manisha.
Manisha, actually, yes, this report was given as VUS. So when we had interpreted the report, see, the report says VUS because the child was not having any other syndromic manifestation and neither the family history. So when we looked at the literature, isolated cognitive mutation is also being identified, and when we do not have any other reason to explain the ongoing SRNS, I think it is prudent for us to link the presence of the mutation with the ongoing steroid-resistant nephrotic syndrome, because the literature supports the existence, the occurrence of isolated steroid-resistant nephrotic syndrome without any other syndromic manifestations. So, I mean, just googling about the report, they may have just said the VUS. Yeah, VUS may be just on the report.
Yeah.
Yes.
So
VUS may be just on the report, Manisha, but taking the whole clinical presentation into consideration, I think he fits into that, the cognitive nephropathy.
Yeah, well, what I would say that it's consistent with that. There's nothing against.
Yeah.
Probably, I mean, because we cannot now further take it because you cannot do the so many others. So I think, I mean, it would be consistent with it. But what point I wanted to make was again, like we need better interpretation of the genetic reports because with so many plethora of reports what we are having, sometimes, many of the times the major report is VUS. If I'm speaking out of experience of so many genetic analysis done, I mean, many of them, you are not able to make sense of the report most of the times. So this okay because there's no other clear evidence and correct to treat the child. That's the only cause.
I agree, Manisha. Like with the availability of these genetic testings, we are trying to do more and more testing, particularly with steroid resistant. So recently, we had one experience like patient presented with steroid resistant nephrotic syndrome. So we have ordered the electron microscopy and genetics also. So electron microscopy revealed basket weaving, suggestive of like in Alports. And when we got the genetic testing done, it showed some tubular variant, when causing a tubular disorder. There was, I mean, completely, there's no correlation between clinical presentation, the electron microscopy and genetics. So I think we need to have more experience and more data, I mean, related to genetic variants so that we can have, some clarity on, which to take significant or, uncertain, I mean, significant, what you said is.
Absolutely. And these collagen 4 mutations are quite common, not only in alpha, I mean, there are so many where you have alpha mutations and all that. So only point I wanted to make was like this genetic tool is another tool in our armamentarium. And I mean, we have to take the whole picture into account, clinical as well as the biochemical, as well as the steroid sensitivity, plus the electron microscopy and the genetic report. So all of them.
Yes,
See,
yes.
but what
As-
I want to make a comment is, Swanlata, in your case, there might be a dual disease which is existing. Actually, Alport's definitely is there because you are telling basket weave appearance is there. Some call for mutation may be there, and some other superimposed.
Mutation was negative. We are
Okay.
actually expecting for this call for mutation, A4 or A5 mutation, but it was negative. But surprisingly, we found some variant of some tubular disorder.
So there may be some dual disease which is existing, but definitely call for mutations are found more often in CKD patients. That is one which I wanted to comment. And of course, we need to look into, in a comprehensive manner rather than just picking it up. Like as Manisha said, VUS, it has to be taken in relevance to the background of the clinical presentation. So what I feel is, in the present situation, since it fitted the clinical situation, I think we conclude that the patient has got percussive nephropathy, though we could not save the patient with the treatment that is available.
Yes, ma'am. Yeah. Many a times that confusion continues, Manisha, in spite of the genetic counseling and genetic counseling reports also doesn't clear the confusion at all many a times. Sometimes also. Any other comments from the audience, Manisha? If no queries and no comments, we just move on to the next session, that is vote of thanks. Thank you very much.
We have final conclusive remarks by Dr. Gangadhar and Dr. Bhushan before the vote of thanks.
Yeah. Dr. Bhushan, sir?
Yeah. Actually, today, all the sessions are actually really good. I think day by day, our quality of our sessions is definitely increasing and improving. The number of cases and the topics we are choosing will be definitely becoming versatile rather than the monotonous one interesting case and one like the way we used to do before. But now we are learning a lot, and probably the nephrology is also expanding into different facets. And luckily, being Hyderabad, being very active city academically and otherwise, we are able to see the different varieties of cases, and we are sharing it also among ourselves. It's very, very good. But actually, I want to give a small suggestion. I don't know whether the organizers would like it or not, but what I would like to tell you is that there's one card, that advertisement card which has been sent showing all the speakers, chairpersons and the photographs. But I feel that it should be predominantly the new people who have become the speakers, like something like Dhananjay has become old already, but the Dhananjay and other people and the residents, I think it's better to have those kind of people, because I have not seen some residents,
Well taken.
some
We'll
people.
change the format. We'll change the format. We'll change the format, sir. We'll change the format.
Please. No, we all of us know. I know you. Everyone knows about me and Dr. Anuradhar, Gangadhar, Manjusha, Swanlata, Manisha Saheb. All of us, know. But new people, because I don't know Dr. Shravan and other. I've not seen them before, and I never spoke to them also. So also the residents who are new in different institutions. We are getting so many residents in our state now, in Telangana, Hyderabad especially, and we need to know each other. Actually, that will be better, good also. So that's the only suggestion. But otherwise, today's program is really good, and we have learned a lot. And I hope to see and listen to such cases again and again in the next few years also. Good.
Thank you, sir. Thank you. Point well taken, sir.
In this session, we are trying to include new faces, sir. So your point is well taken.
Very good.
We try to avoid our faces and put new faces into the invite as well.
Yeah, I think you can have an introductory class for the new entrants. I mean, that is a really good suggestion.
Yeah, so especially if you want to keep my photograph, I will send a different photograph of new photograph of mine rather than the old one.
Yeah, so I
have the same complaint, sir. Thank you, sir. Thank you for raising that.
We should agree with Bhushan, sir. I think there are so many new consultants.
That was the concept of including the members. No, we have started including. So I just I was little, I didn't want it to hurt you now that it has come from you. So I'm confident in removing
we have, Swanlata, we have started inviting chairpersons of the newer faculty in earlier fora as well. So only, let's invite the other consultants who are there in other hospitals. No? So obviously people will think only our faces are seen all the time, as Bhushan said. I think let's change since the inputs have come. I think let's take it in an optimistic and constructive manner, and then invite others.
Point well taken.
Yes.
As always, Bhushan sir is excellent in giving advices and points. Thank you very much.
Comments?
Thank you.
Dr. Gangadhar, please.
Dr. Gangadhar sir? Gangadhar sir? No, sir
I
is
think
not
he might be
available.
busy. So let us go to the vote of thanks. Dr. Karthik, he is given the job of proposing a vote of thanks. I
Vikram
think.
Ankunda.
No, Dr. Karthik, I don't find him. So no issue. I'll just propose the vote of thanks. So I thank all the speakers of today's session, Dr. Dhananjay, Dr. Shravan, and Dr. Toshu. It was, all cases were very interesting and we have learned a lot of things. And I would like to thank all the panelists also. There was a very active discussion and they brought out the very new points. And then it's a true knowledge sharing and upgrading our, enhancing our knowledge. So I'd like to also thank all the audience also. I didn't see their interaction. So I think you should, the audience also, particularly the residents, it's basically a learning for them, as well as of course us also. But I request all the audience and the students particularly to post the queries in the chat box right from the beginning, so that we can take those gradually rather than only the panelists speaking. So when I request your participation in the next, now that new residents have joined now. So I think from today, all the residents have joined this year, residents from Usmania Gandhi and DNB students as well from the other the corporate hospitals. So I want their participation. I also request participation of everybody. So as you have seen, we are trying to be inclusive, and as been suggested by the seniors, Dr. Bhushan and Dr. Manjusha, we'll try to include more people as the speakers as well as the the panelists. So thank you once all. And any suggestions, please mail us. We'll try to incorporate. And probably because the exams are around the corner, we will try to conduct the mock exam as well. And any other academic activities or any other activities under the roof of the Nephrology Forum, so all are welcome. We'll try to incorporate all those things. And we're also looking at patient friendly. Should be some information to the patient as well. Ultimately, the whole goal is it should be a better kidney care. So I think we should also have one extension towards the patient, like something like information, so that we have tried to incorporate our website as well. So as initially we have discussed, we'll try to come up with a newsletter. And I request everybody to share their whatever activities or information is there, please share their events. Thank you.
Yes, Swanlata, a small short comment.
Okay.
See, anyway, patient advocacy you have included. I think let's have another meeting for the website transformations with the core members, so that the inputs are given and then it can be taken forward. That's one. And the mock exam, I will discuss with Kiran and Manisha. The tentative date, probably in the mid of the May. We can have probably 2 days exam. We will anyway reveal the further information regarding the mock exam as well. So the details we'll discuss and we'll let you know. So this is the part of the mock exam and website. And of course, I think we should take forward in whatever suggestions you have made. And advocacy, yes, as you said, patient information advocacy should be in the native language, and it should be done. Yes.
Thank you, Manisha, for the inputs. We'll try to incorporate all those things. So any other suggestion, or shall we close the session? If there are no comments.
Thank you. And actually, this meeting is special because we have Shravan from Periphery, who has actively participated and presented a nice case, and that was an excellent and lucid presentation. Further, we invite everybody from the Periphery to get actively involved with the forum activities. Thank you.
Actually, we have tried to put into 3 slots. One would be from the districts, one would be from the corporate hospital, and one would be from the teaching hospital. So that will cover all the cadres and then across the entire state. So that's how the tentative the program would be. So I request nephrologists from across the state, particularly from the districts. So please come forward and participate. So your voice will be heard and you will be allowed to presentation. This is basically for all of us. Thank you.
Thank you. Good night.
Thank you very much, madam.
Yeah, thank you everyone, and have a safe journey back home, and have a healthy life. And we'll catch you up in the next month with the academic activity, newer academic activity. Thank you. Good night.
Thank you.